one of our cardiac electrophysiology fellows this morning on AID, I would say. He will be talking to us about long QT and reviewing the guidelines. For the guys that are here, just make sure you sign in so you get your credits. And with that, I'll give it to Dr. Alzahrani.
Thank you, Dr. Goulian, for the brief introduction. Thank you, everyone, for coming, and thanks for those who are online. I'm a first-year EP fellow, and today I'm going to go over the 2023 CCS clinical practice update on management of patients with long QT syndrome. I'll start with a case. This is a 21 years old female. She's known to have an anxiety, depression, and alcohol use disorder. She was diagnosed with long QT since childhood. However, and unfortunately, she had missed multiple appointments at CHEO, and she was prescribed Nadolol, but she wasn't compliant to the medication. Back in December of 2023, she presented to the emergency department with nausea, vomiting, chest tightness, and she, upfront to the triage, because she was symptomatic, she was given ondansetron before knowing that she's got long QT syndrome. And here is her ECG, which shows that it's got sinus rhythm. However, her corrected QT interval was about 529 millisecond. Once team was realized that the patient had long QT syndrome, she was admitted or monitored under telemetry to check for any arrhythmias. She was given IV fluids, and she was given her electrolytes were corrected as well. She's got no documented arrhythmia during her stay in the emergency department. In few hours later, her corrected QT interval was to around 549 millisecond. A few hours after her emerge stay, she didn't have any further no arrhythmias documented on telemetry. She felt better, so she was discharged and referred to the inherited arrhythmia clinic. So she was seen at the inherited arrhythmia clinic by Dr. Handsome. She stated that she was not compliant to Nadolol. However, she started taking the medication 2 weeks prior to the visit. She denied any history of syncope, seizure-like activities, or chest symptoms or palpitations. During the clinic visit, she had an ECG that was done that showed she's got sinus rhythm, sinus bradycardia around 50, 55, with a QT that is at 489 millisecond. As you typically done at the inherited arrhythmia clinic, patients get further assessment, including detailed family history. So the patient have family history of Jervell-Lange-Nielsen syndrome and a familial KC NQ1 variant. Her mom was a carrier of that variant as well, and her maternal niece had diagnosis of sensorineural hearing loss, and following genetic testing, she was found to have the Jervell-Lange-Nielsen syndrome, which is an autosomal recessive condition that typically associated with sensorineural hearing loss and long QT syndrome, and her niece had an ICD in place. So I'll pause here for a case. I'll go over the 2023 Canadian Cardiovascular Society clinical practice update on management of patients with prolonged QT interval. So starting with the guidelines, but it's good to first define what is the QT interval. So on the ECG, it basically represents the time of the onset of ventricular depolarization to the end of the repolarization, which is basically the action potential. Physiologically, it is affected by rate, circulating catecholamines, and autonomic tone, which is typically variable and fluctuates um, due to or actually it fluctuates between day and night. So it did affect the long QT in that perspective. So here's the ECG on top, and then the action potential of the ventricular myocardium. We could see here in phase 0, there's influx of the sodium into using the sodium channels, and then phase 1, there's a transient outward of chloride and potassium. Then phase 2, this is phase 1. Phase 2, there's using the long calcium channel, there's an influx of calcium, and then the potassium get effluxed through the rapid and slow channels. The measurement of QT interval typically either manually done or automated using the ECG machines, and ECGs most of the time they do have an algorithm to correct the QT interval, typically using Bizet's formula. The best leads are typically lead 2 and lead V5 to do the measurements, and it typically from the start of the QRS to the tangent intersection with the baseline. There are different factors that could affect the measurements of the QT interval and can make them inaccurate, including irregular heart rate or tachycardia, if there's a baseline artifact, or if there's a wide QRS or bundle branch block, or if there's an abnormal ST to T configuration, as well in cases of pre-excited ECGs as well. It's sometimes challenging to define where to start the QT interval. However, the delta wave typically is a part of the depolarization, so starting from the delta wave to the end of the QT. The ECG machines and Holters do have limitations when it comes to the measurements of correct QT interval, and they typically or could be inaccurate at times, especially when it cannot differentiate the end of the T wave, or if the QRS is wide, and it also doesn't adjust for sex or age. Both manual and automated measurements do not adjust for the diurnal variation in presence or absence of long QT interval, especially in patients with the concealed congenital long QT syndrome. And generally, it's not recommended to use smartphones or smart watches like Apple Watch to measure the QT interval. According to this is pictures from the CCS guidelines, basically a simple approach on how to accurately measure the QT interval. So step by step, you have to first determine the TP line, as probably the line is not obvious here, but the baseline between the P wave and the T has to be determined first, and then a perpendicular line crossing the TP line at the beginning of the QRS or the Q wave, and then at the peak of the T wave, and then a tangent is drawn, the maximum slope of the T wave crossing the TP line, and then this is called the QTA, which is used to estimate or to calculate the corrected QT measurements using Bizet's formula. Some tips and tricks: make sure the rhythm is regular, make sure it's between 60 to 100, which most of the time, I mean, Bizet's formula is very good for normal heart rate, not typically for faster heart rate. Also brought this picture, not from the CCS guidelines, but from another article that was published on the clinical electrophysiology back in May of 2022, and it did show this because there are some caveats. If the T wave does have a biphasic morphology, or if there's a U wave, and sometimes it could be challenging where to start, where to stop. Is it the higher peak of the T wave, or the terminal limb, or so on the left side here, the tangent technique. So it starts from, so the end of the T wave is the point where the tangent to the steepest point of the terminal limb of the T wave intersects with the baseline. Typically here, in cases of U wave, this is the end of the T wave is basically defined as the nadir between the T and the U wave. When manually measuring the QT interval, try to avoid immediate post-cardiac arrest or MI or CNS injury measurements to avoid overcorrection. Bizet's formula used to correct for rate, and this is typically for patients who with normal heart rates of between 60 to 100. And Frederica formula can be used in patients with faster heart rate. And this is the formula here. So the possess basically our interval. So we measure the QT manually, and then on the square root of we'll take the square root of the RR interval. What is a prolonged QT? So the numbers are basically defined according to age. So after puberty to 65 for above age, and according to males or females. So a normal QT for a female is typically less than 460 milliseconds, and for a male is less than 450. A prolonged QT is for females is more than 480 milliseconds and more than 470 milliseconds, and then there's this area, this between 460 to 479 or 450 to 469, which is the borderline, still considered prolonged QT. However, based on the guidelines, this is a definite diagnosis if it's more than 480 for female and 470. There's no sex-related differences in childhood up until the puberty. There's no ethnic or racial differences as well, and typically women have longer QT due to hormonal changes. A normal or a borderline QT interval typically does not exclude congenital long QT syndrome, and this is what we refer to a concealed QT prolongation, which means it doesn't typically show on the resting ECG. However, with further testing or exercise stress test, it could be shown. There's as mentioned, there's an area of overlap between normal, borderline, and prolonged QT, and as shown here in this figure. So 99th percentile in males are above 470 milliseconds and more than 480 in females. However, there's an overlap zone in which there are normal patients. However, there are normal persons, and there are QT prolonged patients. So when to go further with the normal QT interval or corrected QT interval on an ECG. So in cases of high-risk symptoms, including unexplained syncope or seizure-like activities, no obvious reasons, or in patients whose family has history of long QT syndrome, or if the patient is on a QT prolonging medications, or if they do have electrolyte abnormalities with high-risk symptoms. Further testing could be done, including exercise stress test to detect the latent QT prolongation, as well careful look or assessment of the T wave, the QT and the T wave morphology, as well as sometimes abnormal morphology could be associated with congenital long QT syndrome. The diagnosis of congenital long QT syndrome, there are three well-recognized genes. I'm sorry for the, it's probably not, the slide is not typically this way, but probably when I transferred slides over here. So there are three well-recognized genes which are associated with robust evidence for causation and pathology in congenital long QT patients. However, there are less variant with less compelling evidence in other uncommon 14 genes. The most common types represent typically about 75 to 85% of patients, and most commonly type 1. Type 2 comes next with about 35 to 40% of patients, and type 3 between 10 to 15% of patients, could be less than that as well. And there are about 15 to 20% of patients who do not have a recognized or a known genetic variant. The first step in assessment or diagnosis of congenital long QT syndrome is a detailed history, and that starts with the patient factors, including social, mental, past medical history, medications, any drugs used, and then a detailed history into the event of this syncope or unexplained syncope, any seizures or a seizure-like activity. And then one of the crucial parts of assessments of those patients basically is the family history. So specifically asking about any sudden fatal accidents, unexplained drownings, unprovoked seizures in family members, especially those are refractory to anticonvulsants, unexplained presyncope or syncope with strong emotions, with exercises, with loud noises, and then in very rarely any deafness in the family or muscle weaknesses. The second step comes to the ECG assessment and an exercise stress test as well. The ECG, the guideline recommends typically that for a patient, serial ECG recordings should be completed using the same machine, ensuring that the machine uses the same algorithm. And then the exercise stress test, which is the gold standard, with a prolonged prolonged recording into the recovery of period of 6 minutes in adults and 10 minutes in children, and then a referral to an hereditary arrhythmia clinic or cardiogenetic clinic for further assessments and referral for genetic testing. The exercise stress test, it's probably the primary diagnostic test after a resting ECG shows abnormal QT interval. The request has to state, this is different from the exercise stress test that's done for coronary artery disease or ischemic assessment. So it has to state, rule out long QT syndrome, look for abnormal QT during standing and 4-minute post exercise. And this includes stand-up ECG to record the paradoxical lengthening of the QT interval. And the most helpful piece of the test typically is the 4 minutes recovery ECG. However, the whole test should be reviewed and the findings should be documented. The T wave pattern ST segment response to the exercise might also help differentiate or identify the genotype. Typically in long QT type 1, the QT interval lengthens during exercise and remains prolonged throughout yearly recovery. In type 2, it's more characterized by prolonged QT in early exercise and late recovery, and it doesn't substantially change in type 3. And there are no specific pattern for other rare types. This is an example of a stress test that was including the CCS guidelines. So A represents the a normal person. B is basically a long QT type 1, and C is a concealed long QT type 2 patient. As we could see, there is in the peak exercise, there's a decrease of the QT interval in normal patients, and then it typically remains lower than the resting ECG QT interval. When in type 1, during exercises, as we could see, the peak exercise, the QT lengthens further from a baseline of 415 to 459 or 460. However, this goes even longer, more prolonged during the recovery time, and the peak is around 3 to 4 minutes recovery time. In C, this is for a concealed long QT type 2. Still, there is a significant, I think the guidelines basically put this to demonstrate there's significant changes of the QT interval during the peak exercise and recovery. However, the peak QT interval here doesn't fit with the diagnostic criteria, but it could in patients with a prolonged QT interval on resting, or typically goes further to or more prolonged to fit the diagnostic criteria for the long QT. Genetic testing as the third part of the assessment and management of patients with long QT syndrome. There are 3 genes, as mentioned before, which have robust causation evidence. Other less common 14 genes with less compelling evidence. The presence of those non-causative gene variants doesn't make the diagnosis, and the clinical diagnosis could be made or can be made without the or in a genetically negative patients. One of the major rule of the inherited arrhythmia clinic typically is what to do next or further with patients with long QT after the genetic testing. So in genetically negative proband, family should be clinically screened with history, resting, ECG, and treadmills test. But in a genetically positive patient, family should be offered genetic based cascade screening with clinical phenotyping as well. When it comes to long QT and long QT diagnosis or congenital long QT diagnosis, Schwartz criteria is one of the earliest and reasonably validated criteria to diagnose patients with long QT syndrome. This is a modified congenital long QT syndrome based on Schwartz diagnostic criteria or score. Anything above 3 points would make diagnosis of congenital long QT syndrome. So it basically integrates the QT interval, any ECG changes, including Torsades, T-wave alternance, or any notched T-wave in 3 leads, and a low heart rate for age, and then symptoms including syncope with stress or without stress, and any family history of long QT, definite long QT syndrome, and or unexplained sudden cardiac death at age that is younger than 30 years, and the genetic finding as well. So patients with a long QT that is more than 480 milliseconds without reversible causes, then they take 3.5 points, which basically makes the diagnosis. As well, patients who test positive for the 3 well-recognized genes get 3.5 points, and then this makes the diagnosis as well. In other patients, this has to be combined with if the score is, or the probable diagnosis would be between 2 and 3.5. And in those patients, further assessments and judgment by the inherited arrhythmia specialist to make the diagnosis. So when it comes to the management of long QT syndrome, it's straightforward, simple. However, it's complicated and it's not straightforward at times. The major pillars for lung QT syndrome management is beta blockers, avoidance of QT prolonging medications, and lifestyle modifications, including advice about sports, and then special circumstances or special population uh, management. The guidelines have put a general scheme for those patients for the assessment of patients with prolonged QT or corrected prolonged QT. So if there is no reversible causes of QT prolongation, no drugs and electrolytes are normal, then there's no obvious cause for this. Consider congenital long QT syndrome and then refer to an inherited arrhythmia clinic. However, if there's a QT prolonging medication on board and the QT remains remains prolonged in the setting of a normal electrolyte level, then you have to stop the medication, wait for it to wash out, typically 5.5 half lives, and then reassess with a new ECG. If the new ECG shows persistent QT prolongation, then those patients have to be referred to the inherited arrhythmia clinic. If the QT returns back to normal, then this is probably due to the medication, and this patient should be labeled to have a QT prolongation with the medication. If the medication is necessary for the patient and doesn't need to, and the patient needs to be on it, then if the QT is less than 500 and there's no history of syncope or family history of sudden death, which basically is a low risk patient, then this patient could continue on this medication with close monitoring of the ECG and QT. However, if the patient has longer or QT more than or longer than 500, or if they have high risk features, then those patients need to be referred to an inherited arrhythmia clinic for further assessments. The HRS has a very detailed approach and a scheme for patients with long QT, for cardiologists and for inherited arrhythmia specialists as well. And it includes basic investigative assessments, including ECG, exercise stress test, genetic testing, and then for what to do family screening, what to do during follow-up visits, and which patient gets further, like which management and what else to be done for those patients. This study basically, it's a retrospective study that includes about 800 or more than 800 patients with genetic positive long QT patients. Those patients were aged between 18 and 40 years, and actually less than 20% of those patients were on beta blockers, and the 22 years cumulative risk of cardiac events or serious arrhythmic events is shown in the graph here, which the longer the QT, the higher risk of cardiac arrhythmias or cardiac events. So the first pillar, or the first management on the cornerstone of therapy for patient with long QT is basically the beta blockers, and preferably the non-selective beta blockers, either nadolol or propranolol, especially in patients who are in the intermediate or high risk category. If those patients could not tolerate the non-selective beta blocker, then and they are in the low risk category, then bisoprolol could be used in this case, given the side effects, including depression, fatigue, especially for younger patients. The guidelines recommended to start the non-selective beta blockers at lower doses and then up titrate as tolerated with further follow-up with ECGs and clinical assessment. In the guidelines, they recommended to start nadolol at 1 to 1.5 milligram per kg for adults, which is slightly higher than the typical dose that is used in the clinical practice. The next pillar of management comes to the avoidance of QT prolonging medications. A key factor in the management of those patients is they are empowered with education, and their knowledge is or they will or very good teaching of patients and empowering the education, providing them with resources helps, as this is a key factor of management, along with the compliance as well. Patients has part as well in their QT prolonging, in their condition, that includes that whenever they're prescribed a medication, that they should review this with their pharmacist or their prescribing physician, and to make sure they are aware of their condition. Very lovely website. There's the credible.meds.org, also available as a smartphone. Very helpful for patients, for physicians, for pharmacists, or all those dealing with patients with long QT syndrome. This is their website. Has a very good database, and it does. You can easily navigate through the website, and patients can check on healthcare providers as well if they're in doubt of any medication. This is a study that typically shows the importance of beta blockers compliance and avoidance of QT prolongation or QT prolonging medications for more than 200 patients of long QT type 1. It was published back in 2009 in Circulation. It shows you about 27%, or more than 27% of patients who were non-compliant to beta blockers or were using QT prolonging medication suffered a serious cardiac events or serious or cardiac events, compared to less than 1% in patients who were compliant to beta blockers and didn't use QT prolonging medications. A third part of management is typically the lifestyle modification and sports advice. We tell the patient generally to avoid certain triggers based on the genotype of their condition. Previously, in previous guidelines, more than mild aerobic exercises were not recommended. However, this or consistent evidence has shown that there is now those patients, when optimally managed and optimized on medications, and if there's a plan for their sports and shared decision was made, then they could go and they could go to sport. They could be in sports and closely monitored, yes, and they rarely suffer cardiac events. With this, it has basically to be a shared decision between the family, the patient, the family, and the healthcare provider or the inherited arrhythmia specialist and their team, the sports team, as well. That being said, an automated external defibrillator needs to be there. Patients, the coach should be aware, the team should be aware of the patient's condition, and the resuscitation plan should be in place for those patients in cases of cardiac events. This is a review study that was done by the May Clinic team that was published back in 2012 by on JAMA, included, where they reviewed 130 patients from 2000 to 2010. Those patients included, or those patients were diagnosed with type 1 to type 3 long QT syndrome, and they were tailored to different therapies according or based on patients' conditions, and those patients were athletes as well on different leagues from high school, college to professional leagues. And this study and the review showed that only one patient who or actually suffered from a VF shock terminated event. He had a prior cardiac arrest. His QT was more than 550 milliseconds, and that happened during the warm up before the game. And when the patient was discussed further, when this was discussed further with the patient, shows the patient wasn't compliant with the beta blockers, or with the beta blocker therapy. Another retrospective study that was done by the May Clinic team included more than 360 athletes. They were evaluated. 44 of those chose to self-disqualify, and this review included patients with long QT syndrome, CPVT, hypertrophic cardiomyopathy, non-compaction, and idiopathic BF. And most of those patients were basically in the long QT syndrome category. So the study compared athletes to former athletes to assess for breakthrough cardiac events, and to assess for breakthrough cardiac event-free survival. And they have found that those current athletes basically suffered less breakthrough cardiac events. However, this, when it was further statistically analyzed, it wasn't significant. Further therapies of patients with long QT syndrome. So a small group of patients who need further assessment, further management, and here comes the major role of the inherited arrhythmia clinic, on which patient needs to be started on mexiletine, which should be referred for a left cardiac sympathetic denervation, or who needs permanent atrial pacing or ICD implanted. As this has to be a very shared decision, and especially when dealing with younger patients who might be at risk of inappropriate shocks after the implantation of ICD. When it comes to perioperative management, the guidelines recommended to continue the beta blockers during the perioperative period, ensure normal electrolytes around the time of the procedure or the surgery, and avoid QT prolonging medications or anesthetics, including succinylcholine and the volatile sevoflurane, as they do prolong the QT interval. When it comes to pregnancy, the meta-analysis that was done back in 2007 shows that the risk of intrauterine growth restriction in pregnant women with long QT who are using beta blockers is low compared to the risk of proarrhythmia in those patients. And as we could see from the graph here, that the postpartum period is the highest, or the period that has the highest risk of cardiac events in those patients. They recommended that the vaginal delivery is safe. Patients or pregnant women should get adequate analgesia, and the induction time should be shorter during labor. And due to the effects of beta blockers on the fetus, fetal monitoring is recommended during during the labor. This graph here from study that was done back in unpublished on JACC back in 2007, that shows continuing beta blockers is generally recommended throughout pregnancy and postpartum period. And it did show here in the postpartum period that those patients who are off beta blockers typically are, or they have the highest risk of cardiac events compared to pregnancy or postpartum period. Um, so when it comes to the TERSADs, the guidelines recommended that, or it concluded that this is mostly due to beta blockers non-compliance or electrolytes disturbances. The management should include beta blockers, stopping any QT prolonging medications, correcting any electrolyte disturbances. Lidocaine or transvenous pacing could be used temporarily to stabilize those patients. If the event is related to bradycardia, then isopril or transvenous pacing could be the key to manage, and then procainamide and amio has to be or have to be avoided in those patients due to their QT prolonging effects. Acquired long QT syndrome, so in those patients with, if it's not congenital, so classically this is either due to QT prolonging medications or electrolytes disturbances. Ischemia as well, myocardial ischemia as well, is a major contributor to acquired long QT as well. There are less common causes or contributors to acquired long QT syndrome, including severe bradycardia, hypo or hyperthyroidism, and hypothermia, and very rare causes, including Takotsubo cardiomyopathy and inflammatory or autoimmune diseases, because they found that anti-RA-SSA antibody could prolong the QT as well. So in patients with positive antibody could have an associated long QT or acquired long QT. QT prolonged medications and acquired long QT, there are different classes, and they do have different effects on the QT prolongation, as well as the risk of TERSADs. There are interclass differences, and there are differences within the same class as well. It careful with using medications or combining certain medications together that might increase the risk of, that might prolong the QT and increase the risk of TERSADs, and or combining a QT prolonged medication with a loop diuretic or a thiazide diuretic could increase the risk of arrhythmias and TERSADs. The risk of arrhythmia as well could be dependent on the dose of the medication or the renal function as well during the time. That being said, there was a 1 to 2% of the population has genetic polymorphism of the QCNE1 and 2 that might increase the risk of TERSADs if taking a QT prolonging medication. This table shows in different classes, certain medications or certain agents pose higher risk of arrhythmia and QT, and their effects on the QT interval is much more potent compared to other medications that have less effects on the QT and less risk of arrhythmia in patients with long QT, and in patients who need those medications, then it's better to choose the if the patient has to stop the medication, or if the patient has to continue the medication, then probably using an agent with less or minimal risk on the QT and cardiac arrhythmia. Some examples of the drug interactions that increase the risk of acquired long QT syndrome and TERSADs typically could be pharmacodynamic or pharmacokinetic as well. It's basically either using two QT prolonging medications which have two different mechanisms, or using a medication, a QT prolonging medication and a non-QT prolonging medication, however, that affects the metabolism of the QT prolonging medication, or having more than one mechanism for different medications as well, or using with medications that are using potent QT prolonging medications with medications that could affect the electrolytes levels as well. The risk of torsades is higher in patients with QT or corrected QT interval more than 500 milliseconds, or if there's a rapid increase of the QT by 60 to 70 milliseconds. In elderly, in female, and in patients with structural heart disease, those are at higher risk compared to other patients. And the question is when to consider an ECG if the patient or if the patient on a QT prolonged medication, or when do we need the ECG? So guidelines typically recommended that patients before initiating a QT prolonged medication, if there's electrolyte disturbances, or if the patient is already receiving QT prolonging medication, those patients need to get an ECG. And then if the QT interval does not normalize after the stopping of the medication or discontinuation of the long QT or QT prolonging medication, then patient has to be referred for further assessment. The guidelines will went very briefly on the pediatric considerations or pediatric population. Nothing major or no major changes. However, it's the management is challenging given those patients. It's more with families, and it's pretty common to have reflex or vasovagal syncope, especially before the puberty age, and engaging in sports can be promoted with safety planning. And this is a summary of the key learning points by the about managing of patients with long QT syndrome. I'm not going to go over the details of this, but the guidelines summarize the management approach. When it comes to long QT, it's worth mentioning the Inherited Arrhythmia Clinic here at the Heart Institute. We have Dr. Green and Dr. Handsome, who's here in the audience, and he's the director of the Inherited Arrhythmia Clinic. There's also a genetic counselor. The role of the Inherited Arrhythmia Clinic in long QT syndrome management starts from the after the referral phenotype assessment. They also risk stratification, including age, sex, and pregnancy or athletic status. Treatment as well, including pharmacological management of the QT prolonging medications or initiating patients on beta blockers. Also shared decision and planning for device implantations, either atrial pacers or an ICD implant, and then genetic testing, exercise prescription, and enrollment in further studies and genetic assessments for families as well, and further long follow-up. Back to our case. So the patient who was seen at the Inherited Arrhythmia Clinic, she was counseled on the importance of the beta blockers or the compliance to beta blockers therapy and the risk of non-adherence, as this typically it was found that increases the risk of ventricular arrhythmia compared to beta blockers naive patients. Patients was also advised to avoid QT prolonging, as well as to review any medication or any prescribed medication or an over-the-counter medication with their pharmacist or their prescribing physician. And the patient was referred for an exercise stress test to assess for further QT prolongation and for stratification, and she was booked for our next follow-up. Thank you, everyone, for your attendance and for your attention as well. I'll open it to questions. So in patients with bundle branch block, this is a pretty good question, and we see this a lot of times. So in bundle branch block patients, there are different criterias, and there's no a strongly validated technique or criteria. However, the general practice is to remove anything above 100 milliseconds in the QRS duration. So if the QRS is patient's left bundle and like 140 milliseconds, then the 100 milliseconds should be included in the measurements, and anything above 100 is excluded from the measurements. I might also refer this question to Dr. Handsome as well, if he has any further addition to this as well.
I'll use the microphone here just so that they can hear online. It's a good question, Dr. Burwash. I think we don't have a good standardized way of correcting for those patients with an underlying bundle branch block. There is some data looking at it. There's two issues with it. One is how much do you reduce the QRS by? What's a reasonable amount? And then how do you account for rate-related change? Because Bazetz does not work well in that setting. The standardized data, probably the best one actually is to take or to remove 48.5% of the QRS, which is what's recommended. Once you've done that, then often we'd recommend using Hodges as a criteria for correction of the rate rather than Bazetz. And that seems to be the best compromise that we have. There is good data, and people have looked at it. Actually, they tried to find a good model for how we can estimate this. There's reasonable studies looking at pacing from different places within the right ventricle, causing a left bundle branch block, and then looking at how you correct. And also in patients post-TAVI who have developed a left bundle, to then compare their QTs before and after to try and standardize how we correct, but there's no perfect fit. It's one of the things we look at in the clinic, and we're very careful in how we assess these patients. Thanks.
Patients that we should be referring to the arrhythmia clinic. What's your recommendation? Presenting the obvious thing that's monstrous and routine clinic visits.
Yeah, thank you. It's very good. Yeah, so for the online audience, Dr. Golian asked if, like, we see lots of patients with borderline or prolonged QT on ECG without significant or certain further pathologic. What should we do with those patients? When they should be referred, or what should we do as non-inherited arrhythmia specialist cardiologist? I think it's a very good question. And I'm afraid there's no, so the guidelines didn't, specify this further. However, I think it's case by case assessment. It's a case by case assessment. For low risk patients, it could be started on beta blockers also, although it's a tough decision. Or I assume for further for patients with high risk features or high risk or significant or strong family history of long QT, or if they do have, or if they need to be on QT prolonged medications, then I think those patients needs to be referred for further detailed management, assessment and management. Maybe Dr. Handsome does have comment as well.
Yeah, I think that's a great question, and it's something that we see in clinical practice a lot, and it accounts for a lot of the referrals that we have for this query of congenital long QT. Context is everything. It depends on what's going on in that situation. If there are no offending meds and it's over 480 milliseconds, they're above the 99th centile. There's a very high risk in that group that they have congenital long QT. The Schwartz criteria, the original one would have awarded 3 points for a QT over 480. And they would say that a definitive diagnosis is 3.5 points and above. The guidelines have made this a little bit different. They are now awarding 3.5 if you're over 480. So they've changed our benchmark a little bit.
Yeah.
Definitely, if they're over 480 and there's nothing that you think is reversible there, we should see those people. Okay.
Good, thank you.
One last question is, you know, we talked about the 99 percentile, and for men being 470 rather than 480. Now, in the Schwartz criteria, they use 480, which makes sense. But what about a male that's at 475?
So I think that was, yeah, this was mentioned in their
While
go
he's
back
pulling
to
this
the
up, you know, for Dr. Burwash, when you asked QT correction, normally do like 50% of the QRS, and yeah, the 48.5 is a little tough, but it is what was actually studied. Sorry, go ahead.
Yeah, so for males or females between 460 to 479 that have 2 points, which according to the Schwartz criteria makes them at or have probable diagnosis of long QT, and then further features or further assessment has to be integrated in the diagnosis of the long QT. 450 to 459 is 1 point in the score, so that has to be integrated with everything. I hope I answered your question, or at least partially.
You know, the issue is that, so they're saying 480, you're automatically diagnosed with congenital long QT, right? But if in a male, 470 is
It's
the
diagnostic,
upper,
yeah,
right? So
yeah.
it's not diagnostic because based on this criteria, you don't.
That's true, yeah.
So I'm just asking, is did they make any comments about it? Also, the exercise minutes is a bit different as well, right? We use 445 as an example at 4 minutes for it to be abnormal. 480 is very different than the number that we used to be abnormal at 4 minutes of exercise.
Yeah, I'm not sure if I have an answer for this question.
Yeah, that's a good question. Schwartz liked the paper by Raymond Tsai, which looked at how we measure the 1 minute and 4 minute post-exercise QTC, was a game changer. Schwartz liked that so much, he decided to incorporate, but he didn't like the 445 cutoff because of the sensitivity specificity. And he wanted a much higher sensitivity. So he went for the 480 cutoff instead. That was the reason why. So that got incorporated into the Schwartz criteria a few years back. But again, this is a further iteration of that.
Okay. Sure. You got a question? Yeah.
Is the difference between men and women, does it persist after menopause for women?
That's a good question as well, but I'm not sure about that, if I have the answer to
And
this.
a separate question is, for exercise, like your patient, you put them on beta blockers. How does the beta blocker going to affect the exercise measurements? And my third question is, how reliable are we all depend on the automated measurements of the QT that come out? How reliable are those compared to other methods? And is there any AI options for there? So 4 questions.
Okay, so for the first question about the changes after the menopause and comparison to between males and females, I don't have I'm not sure, to be honest, about this. Maybe Dr. Hansen could weigh in this.
Yeah, so there are clear sex-specific changes. Normally we see from adolescence onwards, young boys have the highest risk until they hit puberty, and then their risk just declines throughout life, but the females take off. So definitely during early puberty for a girl up into her late teenage years, their risk just goes up. So usually there's definitely hormonal changes. You're right, when we get to postmenopausal women who have had no events, concern for their risk does start to go down. Yeah. Yeah, we don't change the absolute cutoff. I think when we see them in clinic, we're far less stringent about the number, to be fair. And they've proven themselves. They've been, if they've had no events by that stage, they're clearly a lower risk group.
Yeah, so I think this is, a case to case different. In general, there are patients who couldn't tolerate being on. I assume we do.
No. Don't stop beta blockers. So the case that I gave Anas at the beginning, which was a young lady who's non-compliant, it's very obvious when they're not compliant. So she comes into emerge, not compliant with beta blockers, sinus at 80 with a very long QT. Then knows she's coming to my clinic. She starts taking the beta blockers 2 weeks before, and she comes in with a rate of 47, and the QT shortened. We like to have the serial exercise test because if they've had a baseline not on a beta blocker, it's great to compare it. We want to definitely see a 20% reduction in peak heart rate when they're exercised, and we do see a reduction in the QTC with that as well. So definitely, please don't stop the beta blocker. The other concern is that they have this rebound phenomenon where compliance is a big issue, particularly in adolescents. If you have to really be careful with that patient and with the family, if you consider they're very high risk of being non-compliant and they're a borderline risk, some people definitely in CHIO, they will try and steer away from giving beta blockers in that sense, because if they take it for a few months and they stop, they rebound and their risk actually goes up. So you may be doing harm to those individuals. So we have to be very careful with how we talk to them about medication and the importance of compliance. If they're going on holiday, they're taking rescue supplies in case they lose their baggage because of the risk if they're away. So no, for an exercise test, please, if you're requesting it, specify on there, do not hold the beta blocker before. It wants to be done on the beta blocker.
Yeah, okay.
Yeah, so estimation of the QTC is difficult. We know that when we use the tangent method, we probably are cutting off about 20% of the true T wave from the end. The automated algorithms are not great. So it averages over all of the leads. We prefer lead 2, lead V5, because it seems to give the longest QT on the ECG. The automated approach does not do that. Also, if there is a challenge with the intersection, so the terminal end of the T wave going into the next P wave, it really struggles and it will count often the P wave as well. So one of the most common reasons for a referral actually is because of overestimation of the QT, because we rely on those automated methods. I don't think a lot of us check unless something stands out to say to us, this QT is long. A lot of people, I don't even think, look at the number, to be honest with you. And I think if we do and it's long, we should be trying to check that manually to make sure it's true.
All right. Yeah, thank you so much.
Thank you, everyone. That brings us to the end of rounds. Please join us next week where we're going to be talking about the antiplatelet guidelines. Have a good week.
Yeah, thank you.